Hey guys, how's it going? This is FixerMed. Welcome back to my high yield immunology review for the USMLE Step 1, NBME CBSE, and NBME CAS examinations. This will be part 14 of my multi-part video series covering the entire discipline of immunology in a comprehensive but high yield manner. So without further ado, let's go ahead and get started on today's content. So today I'd like to cover autoantibodies and the diseases that are associated with them. So starting off, I'd like to talk about antiphospholipid syndrome. This is associated with antibodies which include anti-beta-2 microglobulin, anti-cardiolipin, and lupus anticoagulant. These antibodies play a role in recurrent miscarriage and can lead to false positive syphilis screening. Next, we have bullous pemphigold. Antibodies target hemidesmosomes, which lead to a linear immunofluorescence on skin biopsy. Next, we have pemphigus vulgaris, which is where autoantibodies target desmosomes, resulting in a net-like immunofluorescence on skin biopsy. Next, we have Goodpasture syndrome, where antibodies against collagen type 4, anti-GBM, cause linear immunofluorescence on renal biopsy. Next, we have granulomatosis with polyangiitis, also known as Wegener. This is associated with C-ANCA and antiproteinase 3 antibodies, aiding in diagnosis. Systemic lupus erythematosus, known as SLE, is where antibodies which include anti-double-stranded DNA and anti-Smith. Thrombocytopenia is a notable finding, and increased dsDNA, double-stranded DNA, levels correlate with renal prognosis. Moving on. Next, we have drug-induced lupus, known as DIL. This is where antihistone antibodies are associated with various drugs such as minocycline and hydralazine. We have rheumatoid arthritis, rheumatoid factor and anticyclic citrullinated peptide (CCP) antibodies are key markers. Myasthenia gravis. This is where autoantibodies target postsynaptic acetylcholine receptors, contributing to muscle weakness and fatigue. Next, we have Lambert-Eaton syndrome. This is where antibodies against presynaptic voltage-gated calcium channels are associated and often seen in small cell lung cancer. Next, we have polymyositis, also known as dermatomyositis. This is where anti-Jo1 antibodies are common, sometimes indicating ovarian cancer as a paraneoplastic syndrome. Next, we have systemic sclerosis, also known as scleroderma. Limited type is associated with anti-centromere antibodies, while diffuse type is linked to anti-topoisomerase 1 antibodies, also known as SCL70 antibodies. Next, we have primary biliary cirrhosis. This is anti-mitochondrial antibodies are characteristic, which aid in diagnosis. Next, we have autoimmune hepatitis. Anti-smooth muscle antibodies are present, often observed in the autoimmune liver disease. Moving on. Next, we have Graves' disease. So these are anti-TSH receptor antibodies known as thyroid stimulating immunoglobulin, TSI. These are key in disease pathogenesis. Next, we have Hashimoto thyroiditis. Autoantibodies against thyroperoxidase, TPO, and thyroglobulin are prevalent in this autoimmune thyroid disorder. Next, we have pernicious anemia. This is anti-parietal cell and anti-intrinsic factor antibodies contribute to vitamin B12 deficiency and anemia. Next, we have celiac disease. Anti-endomysial and anti-tissue transglutaminase IgA antibodies are diagnostic markers associated with gluten intolerance. Next, we have type 1 diabetes mellitus. Anti-glutamic acid decarboxylase GAD and anti-zinc transporter 8 antibodies are implicated in pancreatic beta cell destruction. Next, we have thrombotic thrombocytopenic purpura. Anti-ADAM TS13 antibodies inhibit von Willebrand factor cleavage, leading to microthrombi formation. Next, we have immune thrombocytopenic purpura, anti-GP2B, and anti-GP3A antibodies target platelets, causing immune-mediated destruction. Moving on. Next, we have heparin-induced thrombocytopenia, also known as HIT. These are antibodies against platelet factor 4 heparin complexes, lead to thrombocytopenia and thrombotic complications. Next, we have Addison disease. This involves anti-21 hydroxylase antibodies, which are implicated in autoimmune destruction of the adrenal cortex. We have rheumatic heart disease. Anti-myosin antibodies cross-react with Streptococcus pyogenes M protein, contributing to valvular damage. Next, we have neuromyelitis optica, also known as Davik syndrome. We have anti-aquaporin 4 antibodies, which are associated with demyelination of the optic nerve in the spinal cord. We have cold autoimmune hemolytic anemia. This is where IgM antibodies target red blood cells, often associated with infections like CMV and mycoplasma. We have warm autoimmune hemolytic anemia. This is where IgG antibodies lead to red blood cell destruction, commonly seen with chronic lymphocytic leukemia. A good way to memorize these autoantibodies are to either make flashcards, either through written means or through Anki, and just memorize them until you're able to recognize the disease and the autoantibodies it's associated with. I know it's a lot to go through at once, but if you need to reference this over and over again, feel free to look through the video multiple times and write out whatever you need to write out while learning this, because it is extremely high yield and it will show up in multiple organ blocks. Anyways, now that we got that out of the way, let's go ahead and look at some questions. We have a 45-year-old female who presents with progressive muscle weakness, especially after prolonged activity. Physical examination reveals ptosis, and difficulty swallowing. Laboratory tests show the presence of autoantibodies targeting postsynaptic acetylcholine receptors. Which of the following conditions is most likely associated with this clinical presentation? All right, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. Clinical presentation of progressive muscle weakness, ptosis, and difficulty swallowing is characteristic of myasthenia gravis, MG. In MG, autoantibodies target postsynaptic acetylcholine receptors at neuromuscular junctions, leading to impaired neuromuscular transmission and muscle weakness, particularly with repetitive use. This autoimmune neuromuscular disorder primarily affects ocular and bulbar muscles. Thus, option C is the correct answer. Therefore, correct answer is C, myasthenia gravis. Let's take a look at why the other answer choices are incorrect. Graves' disease. Graves' disease is an autoimmune disorder affecting the thyroid gland characterized by hyperthyroidism, not muscle weakness. Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disorder leading to hypothyroidism, not muscle weakness. Pernicious anemia. Pernicious anemia results from vitamin B12 deficiency due to autoimmune destruction of gastric parietal cells, presenting with anemia and neurological symptoms but not muscle weakness. Rheumatoid arthritis. Rheumatoid arthritis primarily affects joints, causing inflammation and deformity, but is not associated with muscle weakness like myasthenia gravis. All right, let's go ahead and move on to the next question. We have a 30-year-old male who presents with recurrent episodes of hemoptysis and difficulty breathing. Upon examination, he is found to have linear immunofluorescence on renal biopsy. Autoantibodies against collagen 4, anti-GBM, are detected in his serum. Which of the following conditions is most likely associated with this clinical presentation? All right, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. Clinical presentation of recurrent hemoptysis and linear immunofluorescence on renal biopsy along with the presence of anti-GBM antibodies is characteristic of Goodpasture syndrome. This autoimmune disorder primarily affects the lungs and kidneys, leading to pulmonary hemorrhage and glomerulonephritis. Therefore, correct answer is B, Goodpasture syndrome. Let's go ahead and see why the other answer choices are incorrect. Bullous pemphigold. Bullous pemphigold is characterized by autoantibodies against hemidesmosomes, leading to tense blisters on the skin, but is not associated with pulmonary involvement or linear immunofluorescence on renal biopsy. Granulomatosis with polyangiitis, Wegener's disease. Granulomatosis with polyangiitis typically presents with upper respiratory tract involvement such as sinusitis and nasal ulcers along with C antibodies, but it does not typically involve linear immunofluorescence on renal biopsy. Pemphigus vulgaris. Pemphigus vulgaris is characterized by autoantibodies against desmosomes, leading to mucosal and skin blistering, but it is not associated with pulmonary hemorrhage or linear immunofluorescence on renal biopsy. Systemic lupus erythematosus, SLE. While SLE can affect multiple organs, including the kidneys, it typically presents with a variety of clinical manifestations and a different pattern of immunofluorescence on renal biopsy, such as a full house pattern. All right, let's go ahead and move on to the next question now. We have a 50-year-old female who presents with fatigue, weight loss, and joint pain. Laboratory tests revealed the presence of rheumatoid factor and anticyclic citrullonated peptide, CCP, antibodies in her serum. Which of the following conditions is most likely associated with this clinical presentation? All right, I think I gave you guys enough time there. If you need more time, please feel free to pause the video. Otherwise, moving on now. The clinical presentation of fatigue, weight loss, joint pain, and the presence of rheumatoid factor and anti-CCP antibodies in serum are characteristic of rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder primarily affecting the joints, leading to chronic inflammation, joint deformity, and systemic manifestations. Rheumatoid factor and anti-CCP antibodies are important serological markers for rheumatoid arthritis. Therefore, the correct answer is C, rheumatoid arthritis. Let's go ahead and see why the other answer choices are incorrect. Addison disease. Addison disease is characterized by adrenal insufficiency due to autoimmune destruction of the adrenal cortex, leading to symptoms such as fatigue and weight loss, but is not associated with joint pain or the presence of rheumatoid factor and anti-CCP antibodies. Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disorder affecting the thyroid gland, leading to hypothyroidism, but it typically does not present with joint pain or the presence of rheumatoid factor and anti-CCP antibodies. Systemic lupus erythematosus. While SLE can present with joint pain and various systemic manifestations, The presence of rheumatoid factor and anti-CCP antibodies is more indicative of rheumatoid arthritis rather than SLE. Type 1 diabetes mellitus. Type 1 diabetes mellitus is characterized by autoimmune destruction of pancreatic beta cells, leading to insulin deficiency and hyperglycemia, but is not typically associated with joint pain or the presence of rheumatoid factor and anti-CCP antibodies. Let's go ahead and move on to the next question. We have a 35-year-old male who presents with progressive muscle weakness, especially in the proximal muscle groups. He reports difficulty arising from a seated position and climbing stairs. Laboratory tests reveal elevated creatine kinase levels in the presence of anti-Jo1 antibodies in his serum. Which of the following conditions is most likely associated with this clinical presentation? All right, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. The clinical presentation of progressive muscle weakness, particularly affecting the proximal muscle groups, elevated creatine kinase levels in the presence of anti-Jo1 antibodies in serum are characteristic of polymyositis/dermatomyositis. These autoimmune disorders primarily affect skeletal muscles, leading to muscle inflammation and weakness. Anti-Jo1 antibodies are specific markers for these conditions. Therefore, the correct answer is B, polymyositis, dermatomyositis. Let's go ahead and see why the other answer choices are incorrect. Myasthenia gravis. Myasthenia gravis presents with muscle weakness that worsens with activity, particularly involving ocular and bulbar muscles, but is not associated with elevated creatine kinase levels or the presence of anti-Jo1 antibodies. Rheumatoid arthritis. Rheumatoid arthritis primarily affects the joints, leading to chronic inflammation and joint deformity, but it does not typically present with progressive muscle weakness, elevated creatine kinase levels, or the presence of anti-Jo1 antibodies. Systemic lupus erythematosus, SLE. While SLE can affect multiple organs and present with various systemic manifestations, it is not typically associated with progressive muscle weakness, elevated creatine kinase levels, or the presence of anti-Jo1 antibodies. Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disorder affecting the thyroid gland, leading to hypothyroidism, but it does not typically present with progressive muscle weakness, elevated creatine kinase levels, or the presence of anti-Jo1 antibodies. Guys, that will do it all for the content today. If you guys have any questions, comments, or concerns, please feel free to leave them in the comment section below. If you like this type of video and content, please be sure to leave a like and subscribe to the channel for more content like this. If not, that's all I have for today. This is FixerMed signing off. Have a good day, everyone, and good luck studying as always. Goodbye.